My name is Geoffrey Donnan. I'm Director of the Florey Institute of Neuroscience and Mental Health, in which you are sitting in our house. So welcome to our home. It's wonderful to see you all, particularly from U3A and everyone else who's here from other parts of Melbourne and who knows where. You could be from anywhere. We hope you're from anywhere. I want to first just tell you about this lecture series, and then I'll tell you a little bit about the Florey, and then I'm going to tell you what's going to happen today. So the lecture series, this is our public lecture series, which we're very proud of. We've got 16 this year, and this is the first of the 16. So you are the debutantes for this season. And I won't run through all the topics because that would take some time, but there are topics there that I'm sure would interest every one of you. The Florey Institute is 50 years old. We had our 50th birthday a few years ago. It's entirely devoted to understanding the brain and mind, because the brain and mind is you and me. It's probably the most important part of our bodies. And we understand it so poorly. But we are finding out more and more, and in particular, we're finding out how to make it healthier and healthier, which is exactly what we want. We want all to live not forever, but for at least the time we're here, we want to be extremely healthy. And that's the object entirely of what we're all about. So this first one is all about stroke, and I will immediately state I am a neurologist and I'm a strokeologist. I have been studying stroke excuse me, for my entire career. And during that time, as I'll show you in a minute, I have seen remarkable, absolutely remarkable changes. I'm going to speak for about 10 minutes or so, and then you're going to hear Dr. Katie Bagot, who's sitting over there. She's going to tell you about our marvellous telemedicine program, which brings instantaneous expertise to people all over the state, which is a huge boon for those living in rural and regional Victoria. And finally, we're going to have Professor Amy Brodtmann, who's also sitting over on my right, who's going to tell you all about something that worries us more than most, and that is dementia, how stroke may cause dementia. And even more importantly, she's going to tell us how to stop it, how to prevent it. Perhaps something, again, that interests all of us here sitting in this room. So without further ado, let me start with my short dissertation and tell you all about stroke. I'm going to tell you about, if I could put it this way, the front end, how things begin and how we handle things from the moment a stroke occurs. But firstly, just to put it in context, it is, throughout the world, on average, the second most common cause of death. So it's not an insignificant problem. In fact, in Asia, in much of Asia, it's the number one cause of death. So you can imagine they are even more focused on understanding stroke than we are. In Australia alone, there are about 50,000 every year. And if you do the simple maths, that's about 140 per day, that's about 6 every hour, 1 stroke every 10 minutes. So unfortunately, in Australia, while I'm speaking, probably someone is going to have a stroke, which is exactly what we don't want. And the cost is huge. It costs Australian society about $5 billion every year. So it's a big, big problem. We're not dealing with some small issue. So what is a stroke? it originally came from the Greek term to strike down, which makes a lot of sense because it happens bang like that, instantaneously. And it usually affects one side of the body or the other because just by chance it's in one hemisphere of the brain or the other hemisphere. And as we've come to understand, it's about 85% due to a blockage in a blood vessel. And that's what we see on the right. This is a standard CAT scan, CT scan, which was introduced when I first started training in neurology in 1977. We got our first CAT scanner here in Melbourne. And you can imagine the excitement we had to be able to see for the first time in someone walking around an image which would tell us what sort of stroke it was. So we're able to tell immediately as to that dark area there is where brain has been damaged due to a blood vessel blocking. And sometimes if you do that scan very early, that hasn't actually occurred. You just see normal brain, but that darkness occurs over a period of a couple of hours. These are the normal ventricles of the brain, the water spaces of the brain, which go in here and all around the edge to protect the brain. But about 15% or so are hemorrhages, which are these. And these are basically burst blood vessels. So often due to the blood pressure being too high, the blood or the vessel and or the vessel being too fragile, bang, it goes through and into the brain, and it shows instantaneously. The second it happens, the CAT scan shows that that white area is blood. And as you can see, it's huge. It's occupying about half of one half of the brain, and that causes weakness on the opposite side of the body, and often when it's that big, change in conscious state. So that has revolutionised our management of stroke, and as I say, I was there when we saw it for the first time here in Melbourne. The other enormous advance has been our ability to understand, again from the moment it has occurred, as to whether part of the brain is gone, it's too late, it's dead, to put it bluntly, or it's still surviving. So using MRI, and this is an MRI scan, and we've just colour-coded it, but this part of the brain here is dead. It's too late, but in the green we can tell that the brain is still living. So you can imagine that is incredibly important when we're coming to the next thing I'm going to mention, which is, can we rescue the brain? And when I started, we couldn't rescue the brain, but now we can. And clearly, if there's no living tissue still there, there's no point. But if there's a huge amount of living tissue, then you do everything humanly possible to make that happen. So when I started as a young neurologist in training in 1977, and we said, let's sit down and do a list of all the acute interventions that were working to make people better, improve their outcome once the stroke had occurred. So we drew up the list, and it looked exactly like that. There was nothing. There was zero. We're unable to do anything. So that was somewhat frustrating, but at the same time, an enormous opportunity, because there's so much that one can at least explore as possibilities to improve the outcome once the event had occurred. Ideally, having someone in front of you who's got a dense weakness down one side, get up and walk home. That's our aim, and today we do exactly that. So the interventions now that are proven, and I didn't ever think we'd get to one during my career, but in 2017, this is a list of the proven, scientifically proven interventions that improve the likelihood of you getting up and walking home once you have a stroke. So don't worry about all of this. This is technical stuff, but managing someone in a stroke unit improves the likelihood by about 20%. and improves the likelihood of you dying by about 20%. Clot-dissolving drugs to unblock arteries, because most of the 85% of strokes which are so-called ischemic stroke are due to blocked arteries, and these drugs do exactly that. Aspirin, which you give within about 48 hours of the stroke onset, improves the outcome, particularly longer term. Not much, but you can give it to absolutely everyone. In a limited number of cases, we do what's called hemicraniectomy, which when you get a very, very large stroke, the brain does swell, and we actually just remove a bit of brain, let the swelling gradually settle down. And that's proven to improve outcomes by about 4 times. And the last, which is the one that we've just introduced more recently, is so-called thrombectomy. And that is it's quite logical that the other way, apart from using a dissolving agent, is to put a catheter into the groin, goes up, snakes up into the big arteries of the brain, latches onto the clot and just simply pulls it out. And that improves the likelihood of getting up and walking home about 3 times. So quite remarkable. But, and that's a big but, particularly for this one and this one, that's the clot dissolving agent and the clot removing device, you have to do within a very, very short period of time. And that's why we're constantly educating people about recognising stroke. And we do this in collaboration with the Stroke Foundation, who are wonderful in improving the general public's knowledge about stroke generally. Because if you don't know what it is, you don't know what to do. So if you do suddenly develop weakness down one side, double vision, can't see out one side, numbness or unsteadiness, goes straight to hospital, don't pass go. So those are the 1, 2, 3, 4, 5, which we've now got at our fingertips, which we can use every day if we need to. This is what a thrombectomy looks like. If this is an artery up in the middle cerebral artery and the big artery right there. This is the device that's come up all the way from the groin. Experts put it up. It pushes out in a little, initially little narrow cage, and then the cage just expands. So the narrow, while it's still narrow, it goes through the clot, and then it expands into the clot, and then it's just dragged back down through the tube and out. And you see instances where someone they've got a dramatic stroke in front of you, you go in, you do this, and you pull it out, and the person more or less says, "Thanks very much, when do I go home?" It is that dramatic. But it requires everyone to be able to move very, very quickly indeed. And sometimes the same thing happens with clot-dissolving agents, which are very useful. Now, the final thing I'm going to mention is the stroke ambulance. The stroke ambulance, you could see from those images I showed you, the crucial decision we make is that we must have an image. You can't do anything without an image. And the CAT scan, the early CAT scan, tells us 2 important things. Is it a bleed or is it not a bleed? Is it a blockage or a bleed? And that will tell us exactly that, but the problem is they have to get into hospital to do it. So what we're doing, and we're just starting this program in Melbourne later this year, is we're putting a CAT scan in an ambulance, taking it out in the ambulance, and that's what it looks like. There are a couple around the world. There's the CAT scan, a little donut. In the person goes and sees, is it a bleed, is it not a bleed, and then we know exactly what to do. And then, if I could show you this final slide, this is the time course, if you like, the modern time course, which used to be just stroke, nothing out here. Now we say, let's do the image, not in hospital, but let's do it out in the home, so you can do it perhaps 10 minutes after it's happened, if we're really lucky. Then we know whether it's a bleed, and we've got things I won't talk about, which we can do there. And this is if it's a blockage, and there are these 5 things we can do here to improve the outcome. The whole idea is to make people as well as possible after the event. So these, just to give you a feel for the unbelievable advances that have occurred during my lifetime, which I didn't ever think would happen, and it just always says to me, gosh, what's going to happen in the next 30 or 40 years? And the mind boggles. Hopefully we'll have people perhaps never having strokes, who knows, we'll eradicate it. Perhaps Professor Brodtmann will tell us that, and Dr Bagot. Which brings me to Dr Katie Bagot, our next speaker, who is a key part, which she'll explain, of the Victorian Telemedicine program. And this brings all of these things I'm talking to you about to people all around Victoria. Katie Bagot.
It's always a relief, given that I work in a technology-driven way of delivering healthcare. It's always a relief I can get my slides up. Now, so I'm going to be talking to you today about stroke telemedicine and how that helps deliver optimal stroke care remotely. So no matter where you are, you can get some of these treatments that Jeff's just spoken about. The program is called the Victorian Stroke Telemedicine Program, and it is led by Professor Chris Bladen, who is a neurologist, and he wanted to make sure that there were no strokes left untreated in all of Victoria. Along with Dominic Cadillac, who's a public health researcher, they lead up the Victorian Stroke Telemedicine Program, or VST as we call it, in order to make sure that optimal stroke care can be delivered no matter where you are. So what we're talking about when we talk about telemedicine, it's, if you just think of those, the two parts of that word, tele, it's like television, telephone, it's being able to see things or hear things from a distance, so coming from the Greek tele, meaning from a distance. So here we have a slide, a map of Victoria, and what I want you to do is to look at two things. The first thing to look at are the blue dots. Those blue dots represent a person who had a suspected stroke in Victoria during the course of 1 year. So you can see down in Melbourne, where it's more densely populated, that the blue dots are much more closely together, but that the blue dots actually occur all across Victoria. The second thing I want you to look at are the red crosses. These are the hospitals across regional Victoria and metropolitan Melbourne that actually are able to deliver the treatments that Jeff was talking about, the two time-critical treatments, which is the clot-dissolving drug, thrombolysis or TPA, and then the clot retrieval. Sorry, not the clot retrieval, sorry. The red crosses indicate where the TPA can be delivered, but clot retrieval can actually only occur currently here in Melbourne. So what we were interested in doing is all of those hospitals may not have a stroke specialist on staff, and they definitely do not have a neurologist who is a stroke specialist, a specialist of the brain, on staff 24/7. So depending upon when you had your stroke and you arrived in that hospital could determine whether you had access to a specialist or not. And so what the telemedicine service does is allows the specialists to be accessible to that hospital no matter what time of the day, no matter what day of the year. And I'm going to explain how that works. Thanks to technology now and the Victorian Stroke Telemedicine Program, and of course our funders, both federal and state, we are able to put a virtual neurologist in every one of our 16 regional hospitals, where you saw those red crosses, in every regional hospital 24/7. This means that the ambulances get the patients to the hospitals quickly, and then we can, using telemedicine, can get the specialist to the patient quickly. So here are the 16 hospitals that are able to access the VST program, the neurologist service. And here's the teledoc, that machine there, which is in each of the emergency departments of each of those hospitals. It allows them to, as you'll see, it's on wheels, so they can wheel it to the end of the patient bed, and it allows the communication to occur between the patient and the clinician with the specialist in Melbourne. It allows the sharing of the CT images scans, and as you would have seen from Jeff's talk, it's very important to be able to get those CT scans and to determine whether it's a bleed or whether it's or not, or a clot, in order to determine what the most appropriate treatment is. Here we are, we have a patient presenting in the bottom left-hand corner in the emergency department. They're talking to the emergency department doctor and some nurses, and hundreds of kilometres away is the actual neurologist and the specialist. Thanks to the teledoc and the technology available now, we are able to get this neurologist here into the emergency department. So in this bottom left-hand photo now, you can see the teledoc is at the end of the patient's bed, and Chris, the neurologist who's actually based in Melbourne, is able to have a conversation and can perform an assessment with the patient, talk to the regional clinician and determine what their diagnosis is and then what the most appropriate treatment is. Chris logs onto his laptop or onto his computer, and this is what he sees. At the top of the teledoc is a camera that allows to be able to zoom in and out onto the patient, allows two-way communication, and so Chris can actually, and all of our neurologists, can talk to the patient, ask them to perform tasks to help with the assessment and the diagnosis. And this is what they see down here with Chris down in the bottom corner. Critically, Chris can also see the CT scan. So even though the patient is hundreds of kilometres away and the CT scan is there and they've performed their CT scan there, Chris is able to review those scans and determine what the diagnosis is and what the most appropriate treatment would be. So this means that even though there isn't a stroke specialist actually in the hospital, they're not in the emergency department, but they don't actually even have to be in their own hospital. So this is Chris having been receiving a VST consult call from one of the regional hospitals while he was out for dinner one night, and out he popped out of the restaurant, had a look at the CT scans, spoke to the patient, did the diagnosis, back in time for dessert. I made that last bit up. But so they're obviously very busy as we get more and more hospitals on. We've got 15 neurologists who take these calls. And so sometimes what we'll do is we'll throw them a nice fancy dinner to say thank you very much for all your hard work. But often what happens, at the back there, you'll see two of our neurologists actually doing a consult as well. So what we can tell so far is that the program is still rolling out. We're live in our 16 hospitals. We're still performing the evaluation. But so far there are very promising results. The important thing is that not only is the service being used, it's being used over 1,200 times, but that 1 out of 3 calls isn't actually about a stroke. So the service is broader than helping diagnose a stroke. It's actually more a teleneurology service, providing a wider service than what was originally anticipated. When those calls come through, treatment is able to be getting delivered faster, and every minute makes a difference between the time the symptoms start to the time you get your treatment for the 2 treatments that Jeff was talking about, the clot dissolving treatment and the clot retrieval. So where we've been able to save 30 minutes is an incredible achievement and very helpful to patients who've been able to receive them. The other thing we've been able to do is reduce the risks of delivering some of those treatments, because some of them, they need to be delivered to only eligible patients. So by using the VST service, we've been able to reduce the risks associated with giving thrombolysis by 60%. So you may have seen some of the media attention that the program's received, given that it's changing the way healthcare is getting delivered in Victoria and that the benefits that patients are receiving. We've had a range of media attention both in regional areas and metropolitan. And down in the bottom right-hand corner is a coverage of our 1,000th patient late last year, who was a 15-year-old high school student, simultaneously had a stroke and a cardiac arrest whilst in the hospital, received a VST consult and was able to be swiftly transferred down to the Royal Melbourne in order to have clot retrieval, and is now back at school today. So the vision of Chris was to make sure that every stroke in Victoria was treated. And so what he's been able to do is, by using technology, by using the developing relationships between the metropolitan and the regional clinicians, we've been able to ensure that no matter what your postcode is, no matter where you are in Victoria, if you can get to one of the hospitals and the ambulances will take you there, then you will be able to have access to a stroke specialist in order to help assist, diagnose and assess and plan your treatment. So this is now hoping to be rolled out across Australia. We've been able to do this very successfully in Victoria, but now Chris's next vision is to make sure that there's no stroke left untreated in Australia. Of course, this program requires a significant amount of individuals and organisations to work together, and so it's been really fabulous to be able to work on this project and see that connection between individuals and collaborations across organisations across the state, led by Chris and Dominique, our fabulous 15 neurologists who are on the roster 24/7, the fabulous program manager Michelle Vu, who makes it all happen, and of course all of our regional hospitals and regional clinicians who we work closely with. That's it.
Thanks, Katie. As you could see, a remarkable program. And speaking of remarkable, we now have Professor Brodtmann, who's going to tell us what we all need to know is how to stop having strokes and stop getting the dementing side effects that one may get from a stroke. She'll explain all about that and more. Great. Amy?
Thank you. Okay, so let's move on. We've just heard about some of the most extraordinary advances in stroke medicine in the last 50 years, which have been very much focused on acute medicine and acute treatments, which are absolutely critical, and as a stroke neurologist, I love them all. But we know that whilst there is a proportion of patients who are not eligible for these treatments, and we still need to be doing things for all stroke patients. Stroke unit care is probably the most important one. What happens after stroke is that patients are in hospital for a while and then they recover. They often need some rehab before they go home, and then they go home. And one of the things that people say to me in clinic as a stroke neurologist is, I'm better now, but doctor, my thinking's not as good and my memory's not as good, and tell me about the links between stroke and dementia. So in view of that, I became interested in this some years ago. And what I'm going to tell you about today is I want to tell you the bad news, because the bad news is that stroke and dementia are very closely linked. But I do want to tell you the good news as well, because we can do something to treat this. So I'm going to talk a little bit about the links, a little bit about some of the research we've done here at the Florey to examine those links and what happens to the brain after stroke, and then tell you about what we're trying to do to prevent post-stroke dementia, as well as other dementias from happening. So when we think about, and thank you to my previous speakers to talk a little bit about what stroke is, so you know what stroke is now, and we often think about what are the risk factors, and these risk factors for stroke are the same risk factors as for vascular disease. So the same risk factors for heart disease, heart attacks, and for peripheral vascular disease are those for stroke, in a slightly different order. For stroke, hypertension, high blood pressure is by far and away the strongest risk factor. Another strong risk factor is atrial fibrillation, which is an irregular heart rhythm that people can get, which is in itself associated with vascular risk factors. So they all beget each other, if you like. Smoking and type 2 diabetes are also very strong risk factors. When I'm talking about type 2, I'm not talking about young onset or juvenile or type 1 diabetes. I'm talking about type 2 diabetes or adult, which is associated with a very different metabolic profile. Raised blood lipids, cholesterol, is still a risk factor for stroke, but probably not as important for heart disease. But the two that are having a lot of interest nowadays are a raised BMI or body mass index, or obesity, being fat, and lack of physical activity. So that's stroke. People often say to me, well, I understand what stroke is, what's dementia? And dementia is a medical term that we use to actually encompass a whole range of conditions. Often in the community we think about dementia being Alzheimer's disease and a loss of memory, but in fact dementia refers to a progressive decline in your cognitive function, whatever cognitive function that could be. It's not just Alzheimer's disease or memory loss. And what happens with dementia syndromes is that they're associated with neurodegeneration. And neurodegeneration is a degeneration of the brain, and it's associated with brain ageing and brain shrinkage, which is loss of cells or loss of tissue, and that's called atrophy. So we know that dementia is the number one fear of people over the age of 50, much more than cancer nowadays. So what are the risk factors for dementia? And you'll be surprised to see that they are very similar to those for stroke. So vascular risk factors are now understood as very strong risk factors for the development of Alzheimer's disease. For the last couple of decades, there's been a big focus on genetic causes, and there's no doubt that for early onset Alzheimer's, people who get Alzheimer's in their 40s and 50s, that genetic causes are actually a major component. But for late onset Alzheimer's, people who are getting it in their 70s and 80s, and in fact for all cause dementia, the risk factors are hypertension, smoking, diabetes, to a lesser extent cholesterol and atrial fibrillation, but also lack of exercise and being overweight. So I think that we can see that the risk factors are the same, but does stroke actually cause dementia? Well, the answer is yes, to some extent. There's no doubt that people on the stroke wards are about the same age as those people who are usually diagnosed with dementia. The median age in Australia is 72 for both conditions, a diagnosis of Alzheimer's or diagnosis of your first stroke. So 1 in 3 people on the wards, when I see them, will actually have a history of cognitive decline. But of concern is that an added 10 to 30% of those people on top of that will actually have cognitive impairment or dementia at 3 years following stroke. So there's evidence that not only the vascular risk factors are leading to an increased risk of dementia, but the stroke itself is perhaps accelerating this neurodegeneration. The other evidence for the fact that these conditions are linked is in fact a little bit more indirect. Whilst there's no doubt that the prevalence of dementia across the world is rising, very concerningly, linked strongly to the ageing of the global population, the actual incidence, the number of cases per decade who are being diagnosed with dementia is falling for late onset. And in fact, there's now been 6 or 7 large studies in a number of countries around the world, and they believe that that's linked to the treatment of vascular risk factors. So, and we've actually looked at this also in the Canvas study, which is a study where we're following a group of stroke patients after their stroke, looking at their brains every couple of months or every year or so, and looking at their cognition. There's a particular part of the brain that's very important for memory function that's very strongly associated with Alzheimer's disease and brain shrinkage. We know that patients who have stroke, when they come to the ward and we actually MRI them at baseline, that their hippocampi, these areas of the brain, are in fact smaller than those that you'd expect for healthy controls, people like you in the audience who are healthy and otherwise well. And people who have had prior strokes, they're the red dots there, are in fact have got smaller hippocampi still. So the vascular risk factors are having their effects, and the stroke is also having its effect. After stroke, these parts of the brain actually decline again. So we have quite rapid volume loss after stroke. The red is the control participants, people without stroke. The greens, the different greens, are patients with stroke, and we're seeing that at parts of the brain, their total brain volume, their hippocampal volumes, and another very important gateway centre in the brain, the thalamus, are declining after stroke. So at baseline, vascular risk factors shrink your brain, and the stroke shrinks it further. This is associated with some cognitive change, but the cognitive change really lags behind the hippocampal and the other volume losses. So we don't really see the changes associated with this degeneration until years down the track, hence the reason why we're not seeing the changes until about 3 years afterwards. Okay, so this is all a bit grim, isn't it? What can we do? What can we do to prevent this from happening to me? And that's certainly something. I've got stroke clinic this afternoon, and that's something I'm going to get asked multiple times. So I've done a number of these lectures to the public, and my summary is get checked for your blood pressure, for your diabetes, for your cholesterol, to make sure you don't have any of those strong risk factors for stroke and dementia. Get lean. Depressingly, we're all too fat and we all need to be much thinner. And get fit. Get fit. So get fit and exercise. Exercise and dementia are strongly, strongly linked. We know that physical activity, if we are people who have had low levels of midlife exercise in our 40s and 50s, remembering that midlife starts at 35 demographically, if we are people who haven't exercised much and continue not to exercise into our later life, we have a much higher risk of all-cause dementia. Doesn't matter what sort of dementia. In a study of almost 20,000 people in Northern Europe, the opposite is also true. We know that people who have higher midlife fitness levels and continue that have in fact much, much lower risk of all-cause dementia as well. So being fit's really useful. And again, we've looked at this within our Canvas study where we've looked at parts of the brain that are very important for attention and looked and measured physical activity levels of people over a week in our stroke participants. And we know that there's modulation of certain critical brain centres that are associated with higher levels. So we know that the more you do after stroke, the better your attention is. And we're also seeing modulation in their brains. So in fact, this has led us to want to do an intervention, more than just giving these talks and doing these and trying to influence policy. But we've decided that what we'd like to do is actually see whether or not exercising people after stroke with a cardiovascular style intervention actually helps. So we've started what we call the Pisces study. It stands for Post-Ischemic Stroke Cardiovascular Exercise Study, and we actually just started last year. This was with some seed funding from the Heart Foundation, who are obviously very interested in these sort of programs, because we know that physical activity is really good for your health, for cardiovascular health, for brain health generally, but what we're aiming to do is whether or not we can compare exercise interventions and actually deliver this at 2 months to stop people from developing cognitive decline, to stop people from developing brain volume loss, to stop your brain from shrinking. So, to summarise, vascular risk factors are strong risk factors for dementia and stroke, not just one, not just the other. And stroke and dementia are also linked. However, there is evidence that a lot of dementias may actually be preventable, so it's really important that we get checked and we get lean and we get fit. And we're hoping that intervening with an aerobic exercise intervention may actually prevent cognitive decline. That is, exercise might stop your brain from shrinking. Thank you.
Thank you, Amy and Katie. Very insightful. So now what we're going to do is have a panel of 3, except I'm standing and my colleagues are sitting, and I want you to just ask as many questions as you like, and we will try to answer them. I'm sure one of us will be able to do so. But I want to... Can I start? Amy, what is this funny hippocampus thing? Why do we need it?
So the hippocampus is a structure that's very deep in the brain. It's very extensively connected with many other parts of our brain, but it's actually the gateway to our memories. If we don't have normal hippocampal function, we can't learn new information, and we will never go on to store those memories. So in fact, the hippocampus is affected in many diseases, but it's absolutely critical for normal memory function.
Thank you. Yes.
Just ask, regarding taking aspirin, if you have any sort of sense that you may or someone else may have had a stroke that you don't know, obviously, is it worth them taking half an aspirin or something even before you consult doctors?
Amy, you might handle that,
Okay.
because you're associated with answering it.
Yes. I think that my advice would be no. I think why not consult? If you're saying in the acute setting, as someone who's developing stroke-like symptoms, should I take an aspirin? No, call the ambulance would be my advice. Call the ambulance. Yeah, if you think that you have stroke symptoms, we have an aphorism, doctor, don't treat yourself. So don't treat yourself. Call the ambulance, because it might be a brain, in unlikely situations of brain hemorrhage, you'll make it worse, because aspirin thins the blood.
Yes, in blue, yes.
If you had two blood clots in the calf that was cast because there was a problem requiring it, and you are then on aspirin for the rest of your life, that reduces your risk of dementia and stroke?
Well, perhaps I'll start and then you finish. The type of stroke that's caused by a clot in the calf it's very uncommon, and it requires the clot to go up through the veins to the heart, and then it requires the heart to have a hole in it, which about a third of us do just normally. It then has to get across to the other side of the heart and then go upstairs to the brain. So, yeah, and then, exactly. So firstly, it's an unusual form of stroke, so it's not the sort of stroke that we usually give aspirin for. But Amy, do you want to address as to whether they should be on aspirin forever?
So no, normally the patients who have clots in their legs are usually on another blood-thinning drug, warfarin, for 6 months, and it's very, very uncommon for a clot in the leg to cause a stroke. Often they've got other vascular risk factors, and so we often do have people on aspirin long term, but it's not just for that cause, because the course, when you have a treatment following the clot in the leg, it's for 6 months, limited, stopped, not continuing.
Now, right up the back.
So far exercise, I take it that you physical exercise, but has there been any studies about mental exercise?
In stroke or in dementia? Yes, there's been a lot of work on mental exercises. People remember there's Luminosity that's just lost a large multi-million-dollar lawsuit because they alleged that brain training was of help. And all the patients in my dementia clinic come in telling me how good they are at Sudokus, so I don't have much faith in those either. There is the evidence for brain training shows that it helps in the domain that's trained. So if we're training people to get better at finding a fish on a screen, they do get better, but it doesn't translate. There's no crossover into other fields. There are large studies that are going on at the moment. There's a big study in Sydney as the Maintain Your Brain project, but I think the evidence is fairly poor.
Now, two things. One, I'll take right at the back, but Tom, can you get a microphone to them? Otherwise, if not, I'll repeat the question because everyone can't hear the question.
I wanted to ask about, what percentage of people just die straight off after a stroke?
About 15% would probably die immediately. By the end of 3 months, it's about 20%. And at the end of a year, it's about 30%. So it's a lethal condition. Yes, in the front.
What cardio exercise and how often in a day or in a week is good to prevent dementia or stroke?
Well, that's hard. I think we'll have to ask Professor Brodtmann that one.
So we don't know. We don't know the exact dose, and there's a lot of research that's going on about this at the moment. But the heart foundations of both Australia and the UK recommend 150 minutes per week of cardiovascular exercise. That's exercise so that you're short of breath and that you can speak in short sentences, that you're getting a sweat up. So whatever gives you that amount of exercise, 150 minutes a week, so that's about 5 times a week of 30 minutes a day. So that's quick walking or running or swimming or riding a bike or whatever, plus at least 2 sessions of resistance training to increase strength, because there's evidence that increasing your muscle mass is of importance. So that can be at the gym or yoga or anything that increases strength. So strength training and cardiovascular exercise. We all do far too little. In hunter-gatherer societies, people walk 11 to 19 kilometres a day.
Could I ask a question? Katie, could I ask you a question while we're waiting? What's this about the rest of Australia? Does this mean only Victoria gets this special treatment with telemedicine?
No, well, hopefully not. What we've done is the Victorian Stroke Telemedicine program has covered all of regional Victoria now, but now we're working on the Australian Telestroke network, whereby all of regional Australia will be able to have access to a stroke specialist via telemedicine. It's in the early stages. We're identifying over 40 hospitals in regional Australia outside of Victoria that could participate, and starting to work towards being able to deliver this service nationally.
So a lot of hospitals to go.
A lot of hospitals to go.
16 in Victoria, 40 in Australia, and probably need 200. Probably.
Yeah, it's a fantastic
now,
program.
up the back, Irene, are you going to give where's the...
Hello. First of all, I just want to say thanks. Great talks. Just have a quick question about sleep and sort of the information that poor sleep can lead to increased inflammation and then inflammatory markers leading to poor cardiovascular health. If there's any programs or projects looking at sort of getting fit in terms of sleep hygiene or things like that in terms of stroke prevention, stuff like that.
You want me to answer that? I can tell. She's looking at me. Sleep apnea, which, sleep apnea is where people stop breathing for a period during the night, is a definite risk factor for raising blood pressure, and raising blood pressure is a definite risk factor for causing stroke. In fact, there's a study going on at the moment to see whether attending to sleep apnea while you're asleep is going to reduce the possibility of you developing a stroke. So, in fact, I think it might even be completed, is it? I'm not sure. It might be still underway. And that will help answer part of your question, not all of your question, but at least the sleep apnea component. And it's not really understood whether much of the rest of sleep health contributes a lot to stroke risk, at least. But it's a very good question.
I would just note that one of my PhD students is actually looking at sleep architecture following stroke. So we don't really understand exactly how the stroke itself affects sleep. Sleep's huge in the moment, it's huge in dementia because it's one of the earliest signs in many neurodegenerative conditions. But I'm not aware of any current interventions to improve sleep hygiene. But have a look on the Stroke and Heart Foundation websites, there may be projects.
Now, over here. Oh, back there, sorry.
I suspect a lot of GPs are advising people in my age group and the age group I see around me to stop their statins as they're not necessary as you get older. I don't believe that, but I think that is the advice that may be spreading around.
Never leave home without your American Express. Never stop your statin. There has to be an extremely good reason to stop your statin. We even, if someone has a stroke and they're in their 80s, we as part of the program to prevent the next stroke, we start a statin. And it's pretty clear that statins not only reduce cholesterol, but they reduce inflammation in the arteries and all sorts of other beneficial effects beyond just reducing the cholesterol. So I'd be very nervous about stopping your statin. Yes.
In the case of dementia or particularly Alzheimer's, where are we now in research in trying to detect early enough before the disease becomes visible to everybody? How far are we in this field?
Good question.
In the case of Alzheimer's disease, we're very advanced, I think, in the sense that we actually, in people who have a gene that's known to cause Alzheimer's, there's now imaging that can look at the protein that's associated with Alzheimer's, amyloid, years before they actually develop cognitive symptoms. We still, and in fact there's a study called the DIAN study, which is looking at these people before they even develop the protein in the brain. The problem is, one of the problems is that this protein in the brain is very common as we get older, and it's present in about a third of people over the age of 80. But it's not associated with any cognitive problems. So just detecting that protein isn't going to be enough in terms of detecting whether or not you're going to develop a dementia. So it's still a very complicated field.
But I think it's safe to say, isn't it, Amy, that if you put them all together, say the scan and some blood tests or studies from the spinal fluid, the likelihood that we're going to be able to diagnose it very, very early is quite high.
Yes.
Scientists are all very, very cautious.
Yeah, yes.
She's very cautious.
Yes.
She doesn't like to overpromise.
That's right.
Sorry, we left you.
No, that's okay. I'm just asking more about the rehabilitation options. My brother had a stroke a couple of years ago and was in a coma for the period that you were talking about, having all the exercise and the remediation. And I'm just wondering now, having missed that period, is he unlikely to get any better, or is there still options for improvement after 2 years after a stroke?
Perhaps I'll tackle that. That's a huge question we don't as yet know the answer to. It's one of the unanswered questions. As to, usually we undertake rehabilitation immediately after the stroke. In fact, we're at the moment trying to work out with Professor Bernhardt on the other campuses, doing some wonderful work in this area to determine how early we can start. And then we traditionally do it for about 3 months or so. In fact, most of the funding is around only about 3 months. And there's not a lot of evidence. Let's say someone comes and has never had rehabilitation or has had and wants to recommence. Does it actually help after 2 years? And we don't know the answer to that. And it's an area where we really need to do some very, very serious research. And it's a bit like all research I was mentioning, how surprising it is the progress we've made. That's one of the areas we still need to make a lot of progress, because it's such an important question. Now, where are we up to?
One here?
Yes?
I've never seen a stroke. I've got no idea what they look like. Could you...
I wouldn't recommend it.
No, I don't want to alter that favourable situation. But could you just explain what they look like and what they feel like? I mean, I'm not one to press the panic button, and I'm never sure when one should.
Well, firstly, they happen very, very quickly, instantaneously often, and you suddenly... Well, firstly, talk about a warning. Sometimes people get a little preliminary warning that they don't take much notice of. You can get, say I'm just doing this with my hand, it becomes very clumsy and just won't do what it's told for perhaps even a minute or two, and then seems to be normal. And it might affect the leg at the same time, or it might even affect the face and perhaps a bit of speech. And another common one is because clots go up into the brain, they also go out into the eye. So you might get a little shade coming down and then up again to make your vision a bit impaired in one eye only. And they're little warning signs. We say go straight to the hospital. Do not pass go, just go straight to the hospital. But if you then have a bad one, you're unable to move one side of the body or the other. If it's in the left hemisphere and you're right-handed, you probably can't speak. You may or may not be able to understand. It may get better quite quickly. And if it's a blockage, you won't experience any discomfort. You'll just be probably a bit confused about it all. But if it's a bleed, it may be associated with headache because it may raise the pressure. And that's usually the bleeds are a little bit more, even more serious than the other form of stroke, the blockages. Do you want to add to that, Amy, or Katie?
This is part of her education.
Sure. So the word that I think that everyone should walk away remembering today is fast. So you have to act fast. It's very time critical if you think you're having a stroke. So, or you think someone with you is having a stroke. But FAST also stands for 3 things that you can look for. So F is for if you have some sort of facial droop or the person that you're talking to has some sort of facial droop. A for arms, not being able to raise both arms at the same time is a good test. S is for speech, so slurred speech. People might be having difficulty finding a word or saying the wrong word. And then T for timely, move quickly, call the ambulance, get to hospital. So FAST, F-A-S-T, face, arms, speech, time.
A very, very good thing to remember. Thanks, Katie. Now, where are we up to, Tom?
For families who understand that there's a genetic link when they look through the history of their families, is there any point in people in their 50s who are part of this family of having some sort of testing done so that this amylin can be attended to so that they don't have to face what their parents have been through?
Is this for stroke or dementia?
For dementia, yes.
Amy?
I'm very interested in this. My husband died of dementia last year. I donated his brain to this organisation so that research could be carried out on this very cruel disease.
Thank you.
So if there is, there's sort of 2 parts to that answer. There, in families where everyone has a first-degree relative, so the grandfather, father, and many of the children have the dementia, then yes, it could, and particularly if it's younger onset, it could be one of these genetic causes. The commonest genetic cause is a really genetic risk, and it's associated with this ApoE. And that can run in families as well, but that's more when people have late onset dementia. We know that patients or families with late onset dementia, unless there's a really, really strong link, there's almost never a dominant gene involved, and we don't recommend genetic testing. But my advice would also be, if you're particularly interested, go to a clinic, a memory clinic, or a specialist, and have a discussion about the utility of genetic testing. Unfortunately, it's not covered by Medicare, so you'd have to pay for that.
And there are memory clinics around, aren't there, in most teaching hospitals?
Victoria is quite unique in that we have CADM, as a cognitive dementia and memory service clinic in almost all of our major hospitals. Plus there's some more specialist clinics. I run one at Box Hill, and there's a psychiatry one at across the road at the Royal Melbourne. So we're very lucky in Victoria. We're very well serviced.
Now, the time is almost nigh, but I see...
I think probably we've got time for maybe 2 quick ones.
2 quick questions, because everyone might tire, although I see there's an enormous appetite for questions.
They don't tire. This audience doesn't tire, Jeff.
Now, where are we? Here we are.
This might seem a bit trivial, but what's the latest research on red wine?
That's not trivial at all. That's a very important question.
I took a stroke, Jeff.
I'm passing, I'm handballing.
Can I just maybe take a stab at that? Come later in the year, we've got one of our eminent professors, Professor Phil Beard, telling you everything you need to know about nutraceuticals. Yep. So things that you can eat and drink that are good for you.
Yeah.
The bottom line is that there are elements to red wine that seem to protect you against various vascular diseases, including stroke.
That's right.
It's all very, very good news. Now, I think we had one here that we...
The lady in the yellow jacket, I think, might have had her hand up.
And I'll take one in the middle too, because you're waiting for so long.
I'm talking about fitness. I'm talking about fitness, and most people know how to keep the body fit, but not everybody knows how to keep the brain fit. Could you give us some examples how to do that?
So I think I would disagree with the first part of the statement. Most people don't know how to keep the body fit, or they don't do it. So I think that we know that physical activity is important. The mental activity, the things that we try to encourage people to do is to keep learning. So it's not doing, puzzles in the newspaper, although they're fine, but, learn a new language. What, in fact, the evidence shows is
U3A and other activities.
U3A and other activities, that's right. The evidence shows that, in fact, social interaction is the most important thing. So stay social, stay interacting, do new things, because obviously that's both mental and physical activity. So social interaction is, in fact, the most important thing, probably, for our brains in terms of mental activity, being with people.
And very last question, because you're waiting for so long.
The MTHFR homozygous gene mutation, does that increase your risk of clot or stroke or dementia?
I've
got it running in the family, including my son now. I've got it as well. Just wondering.
Sure. It's associated with an increased inflammation state, and obviously the folate, if you are folate deficient, in association with that. I've never seen any associations with either stroke or dementia in the literature. It's not to say that it's not there, but I've never seen it. It's certainly not something we talk about or we test for.
What a great...
What about McArtison's? My dad ended up getting dementia before he died. Do they have a relation to maybe late onset dementia? A possible link, or... Because it was never like that before, it was just a couple of days before he died.
Yeah, I think that if it was just a couple of days before he died, then I think it was probably more related to him dying. Yeah.
Well, that was part of that was good news. So I'm glad we got that question. So on that note, I'm delighted to have had you here in our home to hear the Florey people talking to you about all their work in stroke, which is one of our major divisions within the Florey Institute. So please join with me and thank Katie and Amy.